Namaste students, today we will be discussing one very important case for both undergraduate and postgraduate students from cardiovascular system. This case will be kept as a main case for both undergraduates and postgraduate students. So let us go with the discussion of the case. The patient by name XXY, she is aged about 60 years, she is a female, occupation, she is a homemaker. Address, she comes from Bangalore. The chief presenting complaints are breathlessness since 20 years and palpitation since 10 years. So the two chief complaints are she is giving history of breathlessness since 20 years and then palpitation since 10 years. Coming to the history of presenting complaint, patient was apparently normal 20 years back when she started noticing breathlessness while climbing stairs. Breathlessness was it used to come on exertion and it is present since 20 years and it is insidious onset and it gradually progressive. The breathlessness gradually progressed from NVHA class 1 to the NVHA class 3. She even gets a breathlessness during sleep when she'll go to sleep. After 2 to 3 hours she go to sleep, she gets breathlessness. So that is a PND history is present. And that PND, she says it will get relieved whenever she is on medication, and because of non-compliance of the drugs at that time the PND will recur back now. And that breathlessness which she gets during sleep after going to 2 to 3 hours will relieve with sitting up position and taking a fresh air. So this is about the breathlessness. Then the next complaint is palpitation. Palpitation, she says, is present since 10 years. It is insidious in onset and gradually progressive. She says it is regular in nature, the palpitation, and it is released with taking rest. So these two are the main complaints whatever the patient is having, and that is the history of presenting complaint. Coming to the elaboration of these two symptoms, students, she says insidious onset of breathlessness on exertion, gradually progressive, and there is history of paroxysmal nocturnal dyspnea. In an approach to a breathlessness, suppose the mode of onset, sudden onset of breathlessness if the patient comes to casualty, as I have been telling on all the previous cases, you will consider acute severe asthma, a tension pneumothorax, pulmonary edema, left heart failure with the pulmonary edema, foreign body inhalation, and pulmonary embolism, a sudden onset of breathlessness. And in the breathlessness, for example, if it is insidious onset, gradually progressive, then you will think of interstitial lung diseases, COPD patients. And if the breathlessness is intermittent in onset and released with taking medications, then you will think of a bronchial asthma, the mode of onset. And here, the breathlessness, whether it is respiratory or cardiac, to distinguish, you should ask two symptoms, very important. One is orthopnea and PND. Orthopnea is breathlessness and lying down is orthopnea. And why you get orthopnea? The mechanism for orthopnea is so whenever the patient will lies down, the blood which is there, the fluid in the interstitial spaces will enter the intravascular space. Then it enters the right heart and pulmonary circulation. So and then the patient will develop breathlessness. That is one mechanism. The other mechanism is whenever the patient lies down, the diaphragm will move less, so there is a less vital capacity. What is PND? PND is patient will eat the food at night, 9 o'clock, will go to bed, probably after 2 or 3 hours at 11 o'clock or 12 o'clock, she gets up with the breathlessness. That is paroxysmal nocturnal dyspnea. In a paroxysmal nocturnal dyspnea, the two mechanisms which operate in orthopnea will also operate, plus another two mechanisms, because during sleep, the catecholamine support to the left ventricle is less and respiratory center is less responsive to the hypoxemia or hypercarbia. Both orthopnea and PND indicates left heart is failed. Our patient gives history of PND, so inner left heart is failed and the cause of breathlessness is cardiac cause of breathlessness. Then you should know what is platypnea and what is trepapnea. Trepapnea is breathlessness on either lying down to lateral side, right side or left side. Trepapnea. Platypnea is breathlessness on sitting position, which usually you get in a pulmonary AV fistulas, atrial myxoma, ball valve thrombus. You get platypnea. Then how do you grade breathlessness? Grade of cardiac breathlessness is NYHA classically used. The grade 1 is breathlessness on unaccustomed activities carrying a heavy weight. Grade 2 is breathlessness on accustomed activities. For example, walking from here around 500 meters till the bus stand. Grade 3 is breathlessness on less than accustomed work. For example, doing cutting vegetables, cooking, making bedding. And grade 4 is orthopnea, that is breathlessness on lying down. Right now, she is lying down comfortably, students. She is on medications also. That may be the other reason why she is not having orthopnea. But if orthopnea is there, grade 4 is the breathlessness. She tells since last 15-20 years, the breathlessness has increased insidiously from grade NYHA 1 to NYHA 3. Then the other ways to classify breathlessness is a Canadian Cardiological Society, where grade 1 is breathlessness on unaccustomed activities. Grade 2 is breathlessness for walking more than 2 blocks. 1 block is 528 feet. Grade 3 is breathlessness between 1 to 2 blocks. And grade 4 is breathlessness at rest. Canadian Cardiological Society of breathlessness. Then you have specific activity scale, where breathlessness patient will develop if they work more than 7 milliequivalents. Then breathlessness more than 5 milliequivalents is grade 2. Grade 3 is breathlessness more than 2. And grade 4 is breathlessness is less than 2 milliequivalent, 2 metabolic equivalents. So 7, 5, 3 and 2. One metabolic equivalence is equal to 3.5 ml of oxygen per kg per minute. 7, 5, 2. Okay, 7 metabolic equivalents, 5 metabolic equivalents, more than 2 metabolic equivalents, and less than 2 metabolic equivalents. This is specific activity scale. Specific activity scale. These are the different types of grading of breathlessness. The other symptom what she had is palpitation. Palpitation, she says, present since 10 years. According to her, it is insidious in onset and gradually progressive. She says it is regular in nature and relieved with taking the rest. And whenever the patient has palpitation, how do you approach a case of palpitation? First, you will ask whether it is intermittent or a sustained palpitation. If it is an intermittent palpitation, it is due to atrial premature contraction or ventricular premature contraction. Then if it is sustained, whether it is irregularly sustained or regularly sustained. Regularly sustained palpitation you get in ventricular tachycardia and supraventricular tachycardia. Whereas irregularly sustained tachycardia you get in atrial fibrillation. Then there are some drugs, the cause of palpitation, which can produce a palpitation. The habits like tobacco, ethanol ingestion, amphetamine, atropine, alcohol, beta-2 stimulant drugs, dariphyllin, theophylline. So all these can produce palpitation, and endocrinological causes like thyrotoxicosis, pheochromocytoma can produce palpitation. Okay, so that is about palpitation. So here she gives history of these two main components. One is breathlessness and another is palpitation. Okay, right. Coming to the other negative history, there is no history of any chest pain. She never gives any history of chest pain. The other cardiovascular system symptoms. There is no history of loss of consciousness. There is no history of any syncopal attack in her. There is no history of any pedal edema, that is leg swelling. There is no history of any leg swelling. And there is no history of hemoptysis. There is no history of fever, just to rule out whether she suffered from any suffering from any infective endocarditis. There is no history of any fever history. There is no blood in the motion, okay, because she has breathlessness and palpitation. One of the cause in India for breathlessness and palpitation is anemia. So there is no hematochezia or melena in the motion. There is no history suggestive of blood in the motion. These are some relevant points in the history. Okay, coming to the past history, she says she had a severe joint pain when she was around 16-year-old. Okay, when she was 16-year-old, she had a severe joint pain. So that is a classic history of rheumatic fever she gives. Classic history of rheumatic fever. Okay, so that rheumatic fever history, whatever she had, the rheumatic fever, she tells that it is very severe, the rheumatic fever history. Then it subsided with the medications, and then she was asymptomatic for 1 or 2 decades, and then she started developing slowly the breathlessness. Typical of a rheumatic heart disease, the symptoms developed. And she even now gives history that she is taking every 21 days the injection. One injection she is taking once in 21 days. So there is no history of diabetes mellitus, hypertension, bronchial asthma, or tuberculosis. No history of previous surgeries. And she used to get hospitalization for her breathlessness repeatedly whenever it get aggravates, and it used to get relieved with the medications, the breathlessness. Family history: she is born of a non-consanguineous marriage, and there is no history of any heart disease in the family. Personal history: she takes a mixed diet, a normal bowel and bladder habits. Sleep is disturbed, as I told, whenever she is non-compliant to the drugs, at that time sleep is disturbed because of the PND, whatever she is getting. And there is no high risk behavior. Drug history, as I told, once in 21 days, she is taking penicillin prophylaxis and she is taking medication for her heart failure symptoms. Pregnancy and birth history: she tells she had 4 children and their age is 45, 43, 41, and 38. And the third one is a female child, and all were uneventful. At that time, she never had a symptom. Whenever she delivered, she never had a symptoms of either this breathlessness or palpitation. So this is about the history, students. So analyzing the history, okay, she has mainly breathlessness and palpitation. These two in the exam also they will ask this breathlessness and palpitation to elaborate. Okay, the different classification of cardiac breathlessness like Canadian classification, NYHA, specific activity scale where more than 7, more than 5, more than 2, less than 2, specific activity scale. Canadian classification, unaccustomed 1 to more than 2 blocks, 1 to 2 blocks, and at rest, NYHA classification. So these two symptoms you should know in this case, the relevant points. She has only these two symptoms and she gives past history of acute rheumatic fever during childhood. So with that past history of acute rheumatic fever during childhood, now you have to think a acquired rheumatic heart disease only. She has breathlessness and palpitation. What could be the cause? It could be either a mitral stenosis with a atrial fibrillation or a regurgitation lesion like a mitral regurgitation or aortic regurgitation, or even aortic stenosis is also a possibility. So acquired valvular heart disease, rheumatic heart disease. Suppose if rheumatic fever is not there, what other differential diagnosis you could have thought? You can think of anemia, rampant in India because of malnutrition, breathlessness and palpitation, anemia. A thyrotoxicosis, they can have a palpitation. So relevant to that, we had asked some points. There is any history of weight loss or sweating. She told there is no history of any weight loss or excessive sweating or weight loss. There is no history of weight loss or excessive sweating. Then could it be, suppose if there is no past history of rheumatic fever, at that stage, third decade, breathlessness and palpitation, could be a congenital heart disease like a ASD or VSD presenting at that age. And IHD is unlikely at 30 years, that to a menstruating female from 30 years. So other DD, suppose if past history of rheumatic fever is not there, you would have thought of anemia, thyrotoxicosis, then congenital heart disease. But she says a classic rheumatic fever history, first diagnosis will consider as acquired heart disease, rheumatic heart disease. Let us see an examination what she is having, what is her cardiac problem. Okay, coming to the examination, the vitals, pulse is 84 beats per minute, the rate, the rhythm is regular, the volume is high, students, the volume of the pulse is very high. And on examine the character, the collapsing pulse is present. How to look for a collapsing pulse? So students, collapsing pulse, okay, you have to put your left hand, okay, on the forearm, then with the right hand you have to feel the pulse, and then suddenly you have to lift the hand above the head. Suddenly you have to lift the hand above the head. I can feel the collapsing pulse. You can feel the through the muscle knock, the arterial pulsation. So she has a collapsing pulse. So she has a collapsing pulse, okay, the character of the pulse, okay, there is no radio-radial delay or radio-femoral delay, and there is no vessel wall thickening. The blood pressure in the right upper limb is 130/70, and the right lower limb is 140 by 80. Temperature, she is afebrile and respiration 18 cycles per minute. Now let us go to the general physical examination after examining the vitals. So let us examine top to bottom in a general physical examination. Okay, first is the pallor. There is no pallor, students. Kan kelag nodi ತೆಗಿಬೇಕಣ್ಣು ಕೆಳಗೆ ನೋಡಿ ಕಣ್ಣು. There is no icterus orgadic. There is no cyanosis. Students, there is no clubbing. You can see there is no clubbing. And edema, we have to look for edema. So 5 cm above the medial malleolus, you have to press for 30 seconds. There is no edema, students. There is no edema. There is no bilateral pitting pedal edema. So next, students, lymphadenopathy. For that, ideally you have to go behind and palpate for lymphadenopathy. She don't have lymphadenopathy. So there is no pallor, edema, clubbing, cyanosis, icterus and lymphadenopathy. Then in pertaining to this case, what are the things, other things you see top to bottom? One is you have to see any mitral phases is there. So any mitral phases is there, you have to see there is no mitral phases. The malar hyperemia in mitral stenosis, you get chronic severe MS hyperemia. There is no mitral phases. Okay. Then you have to look for any stigmata of rheumatic fever reactivation, subcutaneous nodules and erythema marginatum. She is very dark, very difficult to make out the erythema marginatum. Then subcutaneous nodules, you have to look extensor aspect of the olecranon process, extensor aspect of the forearm and arm, occiput, and then in the ankle. Okay, so these are the areas where you look for subcutaneous nodules: olecranon process, occiput, then Achilles tendon. So stigmata of rheumatic fever. Then any signs of infective endocarditis from top to bottom, like anemia, splinter hemorrhages in the nails, ossular nodes, or any splenomegaly and abdominal examination, Janeway lesions in the palms and soles, you have to look, especially if she is febrile. This patient is not febrile, so here, but it's any heart disease, especially RHD, it's our duty to look for signs of infective endocarditis top to bottom. Then one more DD, what we thought was coronary artery disease. So any stigmata of coronary artery disease, like a transverse earlobe crease. Okay, there is no transverse earlobe crease, students. Okay, then arcus senalis, xanthelasma, xanthomas, nicotine staining. She is not a smoker, so in that question doesn't arise, but you have to look. And obesity, she is not obese. So obesity, xanthelasma and xanthomas, tendon xanthomas, arcus senalis, transverse earlobe crease. These are a stigmata of coronary artery disease. So infective endocarditis signs, coronary artery disease stigmata, the rheumatic fever reactivation signs. These are the things which you look in this case relevant. Okay, I'll come back to the other top to bottom some general physical examination pertaining to our valvular lesions after examining our cardiovascular systems. What you have to look. Okay, right. Now let us go to the cardiovascular system examination inspection. Cardiovascular system examination, students, JVP is not raised inner, JVP is not raised. Okay, coming to the proper inspection of the cardiovascular system examination, there is a suprasternal pulsations. I'll focus that and show suprasternal pulsations. So coming to the inspection of the cardiovascular system, students, there is suprasternal pulsations. You can make out here the suprasternal pulsations. You can make out, students, the suprasternal pulsation. You can make out here. Okay, so next in the inspection is apex beat. Apex beat, students, it is ideally you have to look tangentially and from the foot end. Apex beat is not visible. Apex beat is not visible, students. Then any visible epigastric pulsations. Epigastric pulsations are also not visible. Okay, epigastric pulsations are not visible. Then you have to look for any pulsation in the left second space. So this is the angle of Louis. Second space, any visible pulsation is there. So second space, there is no any visible pulsations because that indicates pulmonary hypertension. and left parasternal any pulsations are there, you have to see for mitral regurgitation, and left atrial enlargement. So there is no left parasternal pulsations. Then you have to look any chest deformity, pectus excavatum, pectus carinatum, it is not there. And also you have to look for any precordial bulge. There is no precordial bulge. You have to look tangentially for a precordial bulge. So there is no precordial bulge. These are the inspectory findings what you will look. So I repeat the inspectory findings. There is suprasternal pulsation is present. Apex beat is not visible. There is no visible epigastric pulsations. Precordial bulge is not present, and there is no chest deformity, and left parasternal pulsation is not present, and there is no pulsation in the left side intercostal space, students. Let us come to the palpation. So to palpate for the apex beat, it is felt here, students, just lateral to the midclavicular line, and it is heaving in type. Second space, third, fourth, fifth, sixth space. You have to localize with the finger, is heaving in type, the apex beat. Then epigastric pulsations, you have to feel for the epigastric pulsations. I can feel for the epigastric pulsation here. Then look for the parasternal heave. Parasternal heave, left parasternal heave, students. You have to put your ulnar border. ಉಸಿರು ಹಾಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಬಿಡ್ಬೇಡಿ. ಉಸಿರು ಹಾಗೆ ಇಟ್ಕೊಳ್ಳಿ. Breath held in expiration, you have to give the advice. ಉಸಿರು ಇಟ್ಕೊಳ್ಳಿ ಹಾಗೆ. ಸಾಕು ತಗೊಳ್ಳಿ. There is no parasternal heave. Then any palpable P2 is there, you have to look. Palpable P2 for pulmonary hypertension. There is no palpable P2. Okay, palpable P2. And any thrills in the apex, any thrills are there, you have to look for any thrills. There is no thrill. Thrill at the pulmonary area, thrill at the aortic area. It is not there. Thrill at the pulmonary area and thrill at the aortic area. This is palpation. Come to the percussion, student. The percussion of the heart, the right heart border, you have to percuss the right heart border. Okay, I'll percuss from above downwards. Second space, third space. You have to come the lever dullness. Lever dullness you can make out here. Resonant, resonant. This is dull. Go one space above. Now it became dull. The right sternal border. So right heart border is not enlarged. That will be enlarged in pericardial effusion and aneurysm of the ascending aorta. Then base of the heart, percussion. Yeah, third space. Third space, that is normal. The base of the heart, third space, is normally dull. Suppose if second space is dull, that indicates pulmonary hypertension, okay, or pericardial effusion, the percussion of the heart. Okay, so let me summarize the palpation. Apex beat felt in the left 16 intercostal space and it is heaving in type. Okay, parasternal impulse, pulsation, parasternal heave is not present. There are no thrills both in the base as well as in the apical area. Okay, and there is no palpable P2. Percussion is normal, and in this case carotid shudder you have to look. Okay, carotid shudder. Carotid shudder, you have to palpate for any thrill in the carotids. Because suprasternal pulsations are visible, you have to look for that. Is not there, carotid shudder you have to look. Okay, so this is about the percussion. Now let me auscultate and see what findings she has in all the areas. Okay, all the 4 areas. First I'll auscultate the mitral area. Mitral area, students, S1 is heard and there is no murmur. Tricuspid area, again S1 is heard and there is no murmur. Let me auscultate on the aortic and pulmonary area and neo-aortic area. One minute. Pulmonary area, there is no loud P2, the sound, and there is no murmur. Let me auscultate in the aortic area. Student, aortic area, there is a classic ejection systolic murmur of grade 3 by 6 and it is not conducting to the carotids. But there is a ejection systolic murmur in the aortic area, right side, grade 3 by 6, not conducting to the carotids. And on palpation, I told there is no thrill. So the grade is, that is a 3 by 6. If thrill was there, the grade would have been 4 by 6 or more than that. And it is not conducting to the carotids. So she has that findings. And let me examine in the neo-aortic area whether she has any early diastolic murmur and also left lateral position for a MDA murmur. Side ತಿರುಕೊಳ್ಳಿ left. ಸಾಕಬಿಡಿ ಮಲ್ಕೊಳ್ಳಿ ಸ್ಟಾರ್ಟ್. So there is no MDM murmur. Okay, let me auscultate for the EDM murmur in neo-aortic area. So how do you auscultate for a aortic regurgitation murmur? Very important, students, in the exam they'll ask. The area is in a neo-aortic area or the third aortic space, that is left third intercostal space. Ask the patient to bend forward and breath held in expiration. Let me do for that. Third space. ಮುಂದೆ ಬನ್ನಿ, ಉಸಿರು ತಗೊಳ್ಳಿ, ಉಸಿರು ಬಿಡಿ, ಹಾಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಉಸಿರು ಬಿಟ್ಟು ಹಾಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಬಿಟ್ಟು ಹಾಗೆ ಇಟ್ಕೋಬೇಕು. ಹಾಗೆ ಮುಂದೆ ಬನ್ನಿ. ಸಾಕು ಸಾಕು ಸಾಕು, ಇನ್ನು ಬೆಂಡ್ ಮಾಡಬೇಕಷ್ಟೆ. ಸಾಕು ಬಿಡಿ. So students, on auscultation in the neo-aortic area, there is early diastolic murmur which is a grade 3 by 6 in a neo-aortic area. It is heard. And for that, they'll ask how you auscultate for a aortic regurgitation murmur, that is sitting, bending forward, breath held in expiration. You have to do that. Okay, right. The other system examination, respiratory system, it is normal, students, and CNS and per abdomen, it is also normal. So there is no other significant findings in respiratory, central nervous system, and per abdomen examination. So the classic auscultatory findings, the inspectory finding, you got a suprasternal pulsation. Then auscultation, there is a ejection systolic murmur in aortic area. Then early diastolic murmur in left third space, that is neo-aortic area. Grade 3 by 6, both aortic stenotic murmur and aortic regurgitation murmur. Now, looking back, after you got early diastolic murmur, you have to look from top to bottom the aortic regurgitation signs in her. So what are the aortic regurgitation signs you look from top to bottom? A lighthouse sign, that is alternate blanching and the hyperemia of the forehead, that is lighthouse sign. Then Landau sign. The Landau sign is pupillary contraction and dilatation. Becker sign, the retinal pulsations. Demusset sign, the head nodding with each cardiac cycle. Muller sign, the ula contraction with each cardiac cycle. Then you look for the nails, Quincke's sign, the alternate blanching and contraction of the arteries. All these signs are not there in our students because there is a combination of aortic stenosis with aortic regurgitation. That is why there is no very wide pulse pressure. But she has water hammer pulse and suprasternal pulsations are visible. These two are the positive findings. She has a locomotor brachialis. I will show that the locomotor brachialis. So students, she has a locomotor brachialis. You can make here, you can see here the locomotor brachialis. The pulsations you can make, students. The locomotor brachialis. The pulsation you can make it. So the other peripheral signs like after locomotor brachialis, the water hammer pulse she has. I showed how to look for the water hammer pulse. Okay. Then the pulse is biciferance. You have to look in brachial artery and in the carotid artery. The pulse is biciferance. Okay. Then Trauber's sign. The Traube sign is a pistol art shown which you will hear over the femoral artery, the Traube sign. Then Durozius sign, you will obstruct distally, then a diastolic murmur will be heard. Okay, there is Durozius sign, distal obstruction and diastolic murmur. Okay, that is Durozius sign. Then Hill sign, the blood pressure in the lower limb will be usually 20 mm of Hg till that it is normal. 20 to 40 is mild, 40 to 60 is moderate, more than 60 is severe aortic regurgitation. The Hill sign. Then you have to look for any pulsations in the liver, that is Rosenbach sign. Then pulsations in the spleen, that is Gerard sign. These are the signs which you have to look. She doesn't have all these peripheral signs because she has a combination of AS and AR students. That is why there is no very wide pulse pressure, but locomotor brachialis and the suprasternal pulsations and water hammer pulse, these three signs are present in her students. Okay, right. So she has a moderate aortic stenosis, a moderate aortic regurgitation. These two are the valvular lesions, whatever she is having. She gave classic history of rheumatic fever, acute rheumatic fever during childhood. So this is a case of acute. So this is a case of acquired heart disease, that is rheumatic heart disease. Aortic stenosis moderate, aortic regurgitation moderate. She is in failure because she has a P&D history, but not in pulmonary hypertension because there is no signs of pulmonary hypertension. There is no RVH, there is no parasternal lead, JP is not raised, no pathol P2, no loud P2. So there is no pulmonary hypertension, and she is in sinus rhythm because the pulse is regular, and there is no signs of infective endocarditis. This is a complete diagnosis in her. Okay, students. Both the audio clip of aortic stenosis and aortic regurgitation I have given. You can listen to the audio clip of aortic regurgitation and aortic stenosis, students. Okay. And this is a patient where she gave classic history of rheumatic fever also. So I'll be discussing all the three in this case, that is about the rheumatic fever, about aortic stenosis and aortic regurgitation in detail. And the X-ray and ECG of the aortic stenosis, aortic regurgitation, okay, and the indication of surgery, these PPTs I will discuss at the end of this discussion, students, which I will be given in a PPT in a theory part. So this is a case of acquired rheumatic heart disease, a moderate AS, a moderate aortic regurgitation, no pulmonary hypertension, in sinus rhythm, in failure, and no evidence of infective endocarditis. Okay, this case will be kept for the exam, students, for both undergraduate and postgraduate students. Okay. Okay, students, now let us discuss detail about aortic stenosis, aortic regurgitation and rheumatic fever also, because when I discuss the case of mitral stenosis, mitral regurgitation, I didn't discuss about rheumatic fever, but that's because the discussion was very lengthy. I discussed about the artificial valves in that case discussion and also the cause of multivalvular involvement. Today let us discuss about rheumatic fever also. So coming first to the aortic stenosis, usually a calcific AS, the incidence is around more than 65 years, it is 1 to 2%, and if it is more than 75 years, it is 12%, the incidence of calcific AS. And more than 75 years, incidence of severe aortic stenosis is 3 to 4%, 3 to 4%. Okay. The aortic valve sclerosis, that is the thickening of the aortic valve with calcification without producing aortic stenosis, that is aortic valve sclerosis, is 9% at 54 years of age group, usually at 54 years of age group, and it increases to 42% if it is becomes 81 years of age group, the incidence of aortic valve sclerosis. Then the progression of aortic valve sclerosis to aortic stenosis is 1.8 to 1.9% each year, students. Okay, so this is about the epidemiology. Coming to the causes and pathology of the aortic valve stenosis in India. Probably in last 5 years, 10 years, from the rheumatic etiology, the incidence is changing here also because of the aortic valve sclerosis, because patients are living more longer and longer. They are living 8 decade, 9 decade. Okay. So by and large, the bicuspid aortic valve with calcification is one of the common cause of aortic valve stenosis. Then even calcification of the normal aortic valve and rheumatic heart disease. In India, till last decade, rheumatic heart disease was a common cause for aortic valve stenosis. The bicuspid aortic valve is a cause of more than 50% of the aortic stenosis in Western countries. Okay, and if less than 70 years, they are the cause for 2/3 of the patients, and if it is more than 70 years, they are the cause of aortic valve stenosis in 40% of the cases. So some of the rare cause of aortic valve stenosis are congenital valve stenosis, severe atherosclerosis, rheumatoid arthritis, then ochronosis and alkaptonuria are the rare cause of aortic valve stenosis. Then there can be a fixed obstruction of aortic valve stenosis, a supravalvular stenosis, a discrete subvalvular stenosis, or there can be a dynamic obstruction like in HOCM, where there will be dynamic obstruction to the aortic valve because of SAM movement, systolic anterior movement of the mitral leaflet, which will approximate the septum. Then congenital aortic valve disease could be a unicuspid, bicuspid, tricuspid, or dome-shaped diaphragm. Okay, and unicuspid, usually a fetal valvular AS will occur in infants less than 1 year of age group. Then calcific aortic valve stenosis, there will be a calcification and a senile and degenerate disease of the aortic valve, calcific aortic valve stenosis. Coming to the aortic sclerosis, the risk factors for the aortic sclerosis are obesity, diabetes, smoking, hypertension, hypercholesteremia, renal failure, hypercalcemia, hyperphosphatemia, basal high calcium score. These are all the causes, risk factors for aortic valvular sclerosis. Then even so there will be increased risk of myocardial infarction, those who are having aortic sclerosis. Okay, and 2D echo and CT will establish the initial stage of the calcific aortic stenosis. And if you treat the risk factors for the cardiovascular risk factors, then the incidence of aortic stenosis also will reduce. Then the calcific AS, so the normal leaflet is usually at risk to develop a calcific AS. As I told, the risk factors, the same thing, the obesity, diabetes, hypercholesteremia, smoking, renal failure, diabetes, then high calcium score, okay, hyperphosphatemia. These are all the risk factors and genetic predispositions to develop a calcific AS. These are the risk factors. Once calcific AS was thought to be a problem because of the wear and tear, but now they say there is some biological process involved in developing calcific AS. What happens is in aortic sclerosis, there will be a shear stress because of the blood flow across the sclerosed aortic valve, okay, and then if there is a hypercholesteremia, and because of the shear stress, the hypercholesteremia and the shear stress will induce the inflammation, and that inflammation will produce a myofibroblast differentiation. Okay, this is a biology which is involved in aortic sclerosis: shear stress, hypercholesteremia, inflammation, and myofibroblast differentiation. Then aortic stenosis is a progressive disease and there will be a valve obstruction. It's a progressive disease. Oxidative stress and angiotensin 2 will be elevated in them, and there will be a procalcific stimulus. And it's a valve obstruction will occur because of hydroxyapatite nodules and cartilage and bone formation in aortic valve stenosis. So usually valve leaflets has three things: fibrosa, ventricularis, and spongiosa. Fibrosa is the one which will face the aorta. Then you have ventricularis which will face the ventricle, and spongiosa is the in-between that. And then you have valve interstitial cell. Okay, this is very important. Okay, the valve interstitial cells. Okay, they are the one which will undergo osteogenic reprogramming, and mineralization of the extracellular matrix will occur, and then there will be a progression of fibrocalcific remodeling of the valve. These are all the biological processes which will take place producing calcific AS. Why calcific AS is so much stressed is because the people are living more and more, and this will be the most commonest cause of aortic stenosis in India also in future, because the incidence of rheumatic aortic valve stenosis is reducing. Coming to the rheumatic AS, there will be adhesion and fusion of the valve leaflets. There will be a thickening of the valve leaflets, and also retraction and stiffening, vascularization, and calcific nodules will be formed, producing a rheumatic aortic stenosis. Rheumatic aortic stenosis will be usually associated with aortic regurgitation, or it can be associated with the mitral valve disease also. So, coming to the pathophysiology of the aortic stenosis, first you should know the aortic valvular anatomy, then valvular hemodynamics, then hemodynamic consequence and symptoms. Under these four headings, pathophysiology will be discussed. So, first is only stage A. Stage A is at risk for aortic stenosis. Only there will be risk factors for aortic stenosis, but there won't be any symptoms here, and there won't be any hemodynamic consequences. But the valve hemodynamics, the aortic V maximum, okay, the velocity across the aortic valve V maximum is less than 2 meter per second in the stage A. Less than 2 meter per second in stage A. Whereas stage B is a progressive AS. It is classified into mild and moderate. Mild and moderate. In a mild, the aortic valve V maximum is 2 to 2.9 meter per second, and the gradient is less than 20 mm of He across the aortic valve and LV. That is a mild. Moderate is the aortic valve V maximum is 3 to 3.9, and the gradient is 20 to 39 mm of He, the gradient. So, moderate stage B, progressive AS, moderate is aortic valve V maximum is 3 to 3.9 meter per second, and the gradient is 20 to 39 mm of He, and there will be early diastolic dysfunction in the hemodynamic consequence. Here also there won't be any symptom in stage B. So, stage B is mild and moderate aortic stenosis. Then you have stage C. Stage C is asymptomatic severe aortic stenosis. Asymptomatic but severe aortic stenosis. So, it is graded by the V maximum across the aortic valve more than 4 meter per second. The gradient is more than 40, and the aortic valve area is less than 1 centimeter square or 0.6 per meter square body surface area. And it is classified the stage C into C1 and C2 depending upon the ejection fraction. If ejection fraction is more than 50, it is C1. If it is less than 50, it is C2. Okay. And in both C1 and C2, because they are asymptomatic, you can do exercise tolerance test, okay, to detect whether they develop symptoms or not. And then you have a very severe aortic stenosis where the V maximum across the aortic valve is more than 5 meter per second, and the pressure gradient is more than 60 mm of He. Okay, so this is asymptomatic severe AS C1 and C2 depending upon ejection fraction less than 50 or more than 50. Next is symptomatic severe AS. Here there will be a symptomatic, that is stage D now. Stage D aortic stenosis. Symptomatic severe AS. So here it is classified under 3 headings. Careful students. D1, D2 and D3. D1 is, it is a symptomatic severe AS and high gradient AS. So here the ejection fraction will be more than 50. Okay. And the other features of severe AS will be there, like a V maximum more than 4 meter per second, gradient more than 40, aortic valve area less than 1 or 0.6 per meter square body, and EF will be more than 50. The high gradient, severe symptomatic AS, and symptoms will be present here. Then D2 is a severe symptomatic AS but low gradient. Here EF will be less than 50. So here the aortic valve area will be less than 1 or less than 0.6 per meter square of the body surface area, and EF will be less than 50%. But if you do dobutamine stress echocardiogram, at that time V maximum may be increased to more than 4 meter per second. The D3 is very careful students. Here it is here also a low gradient AS only. Low gradient AS, symptomatic severe AS, but EF will be normal AF. So it's a paradoxical low flow severe AS. Why even if EF is normal, low gradient? Because the LV volume is small. It has become hypertrophied and small, So the stroke volume is very less. It is less than 35 ml per meter square, the stroke volume. So though the EF is normal, because stroke volume is less, because the LV cavity is reduced, the gradient is reduced. So that is why it is a normal EF, but low gradient severe AS student. So this is stage D. So stage D is classified into D1, D2, D3, and stage C, as I told, is asymptomatic but severe AS. Depending upon EF, classified into C1 and C2, more than 50%, less than 50% EF. So this is the pathophysiology classification of the AS given in Brown 1 students. Okay, for a postgraduate students, some of the examiners may ask, so you should know about this. So the normal aortic valve area is around 3 to 4 centimeters square. Okay, and the mild ASC is the valve area is 1.5 to 2, and the V maximum is 2 to 2.9, and the gradient is less than 20 mm of Hg between aortic valve and left ventricle. Whereas the moderate AS, the valve area is 1 to 1.5. Okay, the V maximum across the aortic valve is 3 to 3.9, and the gradient is 20 to 39. And severe AS, the valve area is less than 1 centimeter square, the V maximum is more than 4, and the gradient is more than 40 mm of Hg. This is how you classify the aortic stenosis into mild, moderate, and severe aortic stenosis. Okay, right. Now coming to the other pathophysiological features, in aortic stenosis there will be hypertrophic myocardial remodeling. So because of there is obstruction to the LV, the LV will undergo severe hypertrophy. This hypertrophy doesn't depend not only on the aortic valve stenosis, it also depends on the sex, the genetic predisposition, the vascular load, and the metabolic abnormalities. Okay, and here because there is a LV diastolic dysfunction, you need atrial support for the LV filling. So whenever there is a atrial fibrillation or a AV dissociation, the patient will become very symptomatic because atria cannot contribute to the LV filling which is undergoing LV diastolic dysfunction. Okay, right. Then myocardial fibrosis, this entity is regaining importance of late myocardial fibrosis. Even if the patient who are having a normal ejection fraction with a myocardial fibrosis, they will be symptomatic. So those who have before aortic valve replacement of the myocardial fibrosis, even after aortic valve replacement, they remain symptomatic and the prognosis is very bad. Those who are having a myocardial fibrosis. Okay, right. They fare very poorly. Then pulmonary and systemic vascular resistance, if there is an increased systemic vascular resistance, then there is a worse clinical outcome. Okay. Then the patient, why they develop myocardial ischemia in aortic stenosis? What is the mechanism? See, whenever there is a hypertrophied left ventricle, then there is an increased systolic pressure, okay, of the LV because it has to forcefully contract against the aortic valve. Then there will be a prolongation of the ejection because aortic valve is stenosed. All this will increase the oxygen demand, students. At the same time, because of the hypertrophied muscle, there will be decreased capillary density, coronary capillary density in the ventricular muscle, and there is a decreased diastolic interval and increased left ventricular diastolic pressure. All these things will reduce the oxygen supply. This supply demand mismatch will produce the ischemia in aortic stenosis. Okay, right. So coming to the clinical presentation, students, so they'll have a syncope, angina, dyspnea, SAD. Okay, in the order of frequency, they experience syncope. Okay. So coming to the clinical presentations, in the order of frequency, first they experience syncope, then angina, then dyspnea, students, in aortic valve stenosis. The syncope, the mechanism is there is a fixed obstruction, that is one mechanism. Then systemic vasodilatation is the other mechanism. Abnormal baroreceptor control is the third mechanism. Then baroreflex pathway and vasodepressor pathway. Okay, is another mechanism. So abnormal baroreflex, vasodepressor action. Okay, then peripheral vasodilatation. Then a fixed obstruction to the LV because of aortic valve stenosis. These are the four mechanisms. Okay, why they develop syncope? Because LV will contract forcefully, there is a vasodepressor mechanism. There are the four mechanisms why they develop syncope. Syncope they may get even on a resting position if they develop heart blocks. Okay, if they develop heart blocks and AV blocks and atrial fibrillation. Then why they develop angina? As I told before, because supply demand mismatch. Okay, there is an increased demand because of hypertrophic LV, increased systolic pressure, and also prolongation of the ejection. There is a decreased oxygen supply because of decreased capillary density, increased left ventricular end diastolic pressure, and decreased diastolic interval. So they develop angina. Then they develop dyspnea. Dyspnea is because of LV diastolic dysfunction, increase in the LV end diastolic pressure, and decreased cardiac output. This is the cause of dyspnea in aortic stenosis. 50 to 70% the bicuspid aortic valve usually present in the age of 50 to 70 years, whereas calcific AS will present in the age group of more than 70 years. Still, in more than 70 years, bicuspid aortic valve will account for at least 40% of the cases, students. Okay, right. Then angina can also occur because of the calcific emboli to the coronary artery in aortic stenosis. So these are the symptoms what you get in aortic valve stenosis. Coming to the physical examination. Physical examination, as I told, the pulse should be a low volume and late peak. Pulses parvus et tardus. But this patient had associated aortic regurgitation. That is why you get a high volume pulse in her. Or else, if isolated AS means, which is pulses parvus, low volume et tardus, late peaking. Okay. In the blood pressure, the systolic decapitation will be there. Okay. Systolic BP more than 180 significantly rules out a significant aortic stenosis. That is called a systolic decapitation in aortic stenosis. Okay. Right. Then, on examination, the apical impulse will be forceful. Our patient also had heaving apical impulse. A sustained heave was there. Okay, apical impulse. You get that in systemic hypertension, aortic stenosis, heaving apical impulse. Okay. Then you will get ejection systolic murmur in a aortic area, which is conducted to carotid in a valvular AS. Our patient had a ESM in aortic area, but it does not conduct into carotids. Okay, ESM in aortic area, and A2 will be muffled. Okay, and you may get a single S2, that is P2 in aortic stenosis. There are three reasons. One, because of the late occurring of the A2, it may merge with the P2 producing a single S2, or there may be calcification of the aortic valve producing a single only P2, or sometimes P2 may merge in the systolic murmur itself. Okay, all these things will produce a single S2 in aortic stenosis. Sometimes, especially in aortic sclerotic AS, the murmur what you get in aortic area are better heard in the mitral area. The high frequency sounds are conducted to the mitral area, that is known as Gelliverden phenomena. Okay. Then coming to the dynamic auscultation in aortic valve stenosis, the murmur will increase with squatting and hand grip, whereas it reduces with standing and Valsalva maneuver. The atrial fibrillation and ventricular premature beats will alter the murmur in aortic stenosis, okay, but not in mitral regurgitation. Where in mitral regurgitation also you get a systolic murmur, you may have difficulty in distinguishing from aortic stenosis. AF and VPC usually doesn't alter the quality and intensity of the murmur, okay, whereas in aortic stenosis they alter it. Come to the diagnostic test, the ECG will show LV strain because of hypertrophy. The X-ray will show a rounding of the LV. The ECG and X-ray I will show in the PPTs, okay, which I will discuss after these examinations, after this discussion, students. In the end, I will put a PPT of that, okay. Then you can do excess tolerance tests, whether they are in asymptomatic patients, whether they develop symptoms or not, okay. And cardiac CT for a calcification of the valve, and PET CT, okay, for yearly you can do PET CT for the progression of the calcification, how it's progressing, to know that. Then catheterization routinely doesn't require, but if there is a discrepancy between your clinical finding and non-invasive testing by 2D echo, or non-invasive testing cannot clearly tell about the diagnosis, then you will do a catheterization, or before surgery you will do a catheterization in aortic valve stenosis. Then valve area in 2D echo you will establish by doing continuity equation. Let us not go detail into those continuity equation and all, maybe required for a DM students. Okay, right. Now, what is the disease course in asymptomatic patients and what is the disease course in symptomatic patients? Disease course in asymptomatic patients, to know the disease course, you have to do in a mild cases once in 3 to 5 years 2D echocardiogram, in a moderate cases 1 to 2 years, and in a severe AS cases 6 to 12 months you have to do 2D echocardiogram. The factors which are associated with the rapid progression, as I told, hypertension, diabetes, hyperlipidemia, smoking, hypercalcemia, renal failure, hyperphosphatemia, all these things will aggravate the progression of the symptoms. Then aortic stenosis will develop at a rate of 16% at 1 year into aortic stenosis, the aortic sclerosis, and but only 2.5% will have a severe AS at the end of 8 years, students, at the end of 8 years. Then the Doppler aortic jet velocity is the one which determines the prognosis. For example, if the Doppler aortic valve jet velocity is 3 meter per second, then the survival is 84% at 2 years, but it reduces to 21% if the velocity increases to 4 meter per second across the aortic valve, the jet velocity. So that will determine the prognosis in asymptomatic patients. Then there is some risk stratification in the patients with the severe aortic stenosis. Okay, the risk stratification in asymptomatic patients and symptomatic patients. In asymptomatic patients, the moderate to severe aortic valve calcification, then very high aortic velocity, that is more than 5 to 5.5 meter per second, then rapidly increasing aortic velocity across the valve, or increased hypertrophy of the LV, myocardial fibrosis, then decrease LV longitudinal systolic strain, then abnormal exercise stress, increased BMP, pulmonary hypertension. All these help in the risk stratification of the patient with severe AS. Then also, in a symptomatic aortic stenosis, the lack of contractile velocity, for example, in a D2 type, where there is a symptom, a severe AS, but low ejection fraction, and the gradient is very less, okay, and gradient is less than 20 mm of Hg, that indicates a very bad prognosis, okay, that is stratification in patient with severe AS, and fibrosis, frailty of the patient, then oxygen dependent lung disease, renal failure, very high elevation of BNP, and a very high STS score. STS is Society of Thoracic Surgeons. Score. All these things indicates a very bad prognosis and help in risk stratification in patients with severe AS students. Okay. Now, this is in asymptomatic patients, the progressive, the how to gauge the progression, okay, the disease course. In a symptomatic patients, if you don't do the aortic valve replacement, they usually die, students. So the life expectancy is 1 to 3 years, okay, especially if the cardiac output is very less, ejection fraction is very less, they have very poor outcome, and there is a high incidence of sudden cardiac death in these patients who are symptomatic, students. Okay. Surgery has been advised to our patients, but she has denied it. Okay, so we are telling her to get the surgery done, aortic valve replacement, to our patient. Then, as I told, the classification of severe AS is little tricky here. Again, I just Braunwald has given classification of severe AS. Severe AS is either asymptomatic or symptomatic. If it is asymptomatic, it is C. In C, C1 and C2 depending upon the ejection fraction. Ejection fraction more than 50 is C1, less than 50 is C2. So severe AS, the thing is V maximum will be more than 4, the gradient is more than 40, and the aortic valve area is less than 1 or 0.6 per meter body square surface. This is C1 and C2. Then symptomatic severe AS is D. In D1, D2, D3. In D1 is EF is more than 50. In D2 is EF is less than 50. Okay. And in D3, the EF is normal but still low gradient. Why? Because the stroke volume is less, because LV cavity is less, LV is thicker, the stroke volume is less than 35 ml per meter square. Okay. And because of the smaller stroke volume, the gradient is less. It's a paradoxical low gradient AS with the normal EF, the D3 variant, students. Okay. Right. So that's about the classification of the severe AS. Okay, Braunwald has given all the flow diagrams with the severe stage A, B, and C and D. You can go through it, students. Okay, some of the examiners may ask, if you want to score high marks, you may have to know this stage A, B, C, and D in aortic stenosis, students. Coming to the treatment, the medical line of management, you will give ACE inhibitors, then nitroprusside. Statins have not shown to be beneficial in aortic stenosis. And you can give a phosphodiesterase inhibitor. It has the same role as nitroprusside, where they reduce a preload, afterload, they reduce a congestion. Then balloon aortic valvoplasty used as a bridge therapy in aortic valve stenosis. Those who cannot undergo surgery or as a bridge before getting a aortic valve replacement, or in a pregnancy you can do aortic valve valvoplasty, balloon aortic valvoplasty. Then aortic valve replacement, the indications are all symptomatic patients they should undergo, whereas in a severe asymptomatic patients they have to undergo aortic valve replacement if the ejection fraction is less than 50%. That's one indication. Or if the BP becomes hypotensive response with the excess testing, or with excess testing if they become symptomatic, or if they are undergoing other surgeries like CABG in a severe asymptomatic case, they have to undergo valve replacement. Or if there is a rapid progression of the calcification, and if there is a low risk for surgery, and if the patient preference in a asymptomatic severe AS, they have to undergo aortic valve replacement, students. Okay, and here there are two things. One is surgical aortic valve replacement, and of late, the very recently it has come transcatheter aortic valve replacement or implantation. That is TAVR or TAVI. Okay, right. Now, the risk factors associated with the increased mortality in the surgical aortic valve replacement is a high NYHA classification, impaired left ventricular function, then associated coronary artery disease and advanced age indicates mortality more in a surgical aortic valve replacement. Okay, then the factors to consider whether they have to undergo surgical aortic valve replacement or transcatheter aortic valve replacement. Which are the factors you will consider? The age of the patient, LV function, then is pulmonary function, renal function, frailty, comorbidities, disabilities, the valve anatomy, and associated coronary artery disease. All these will decide whether it will undergo a surgical aortic valve replacement or a transcatheter aortic valve replacement. Okay, right. Now come to the indications for the intervention in aortic stenosis. All symptomatic patients, the D1, D2, D3 I told. So D1 is EF is not more than 50, severe AS symptomatic. D2 is severe symptomatic AS but EF is less than 50. D3 is severe symptomatic but EF is good but the stroke volume is less, so it's a low gradient AS D3. So all these three will undergo aortic valve replacement. Okay, but in this patient, if surgical risk is low, you will do a surgical aortic valve replacement. If surgical risk is very high, then either you can do surgical or transcatheter aortic valve replacement. And if it's very prohibitive surgery, then you have to do a transcatheter aortic valve replacement only, because they'll sustain that operation more compared to a surgical aortic valve replacement, students. Okay, or you can even if TAVR, if it is not possible, you have to give only a palliative therapy. This is in a symptomatic patient. Suppose the patient is having no symptoms. In them, how do you operate? In whom you will operate? If there is no symptoms, a very severe AS, V maximum across aortic valve is more than 5 meters per second, and if there is a low surgical risk, you have to operate in them. Or if V maximum is 4 meters per second, if they become symptomatic during excess tolerance test, if they develop hypotension, you have to operate them. Or in a severe asymptomatic EAS, if EF is less than 50, you have to operate in them. Or if there is a rapid progression of the calcification and a low surgical risk in a severe asymptomatic AS, you have to operate them. In symptomatic, you have to operate, no doubt about that. But whether you will do a surgical aortic valve replacement or a TAVI depends upon the risk factors, the age you will consider. Okay, this is one, the indication of intervention. The other is, in a severe symptomatic AS, how do you choose whether surgical aortic valve replacement or a transcatheter aortic valve implantation? Suppose the life expectancy is less than 1 year, only palliative therapy will be student. If life expectancy is more than 1 year, then if mechanical valve is indicated, then you do mechanical surgical aortic valve replacement. If bioprosthetic valve is indicated, then only the question arises whether you are doing a surgical aortic valve replacement or a transcatheter aortic valve replacement TAVI. Then next question arises in this scenario is whether transfemoral aortic valve approach is possible or not. Transfemoral aortic valve replacement approach is possible or not. Suppose if transfemoral aortic valve replacement approach is possible, in a high risk patient, you will do transcatheter aortic valve replacement only, TAVI you will do. Suppose if the patient is a low to intermediate risk, and then the age factor will come into picture. Okay, here suppose the patient is less than 65, then you do a surgical aortic valve replacement only compared to a transcatheter aortic valve replacement, a strong indication. If the age has increased 65 to 74, then again you will do surgical only compared to a TAVI, but it is not a strong recommendation, a weak recommendation. If still the more age 74 to 84, then here TAVI is better than surgical aortic valve replacement, but a weak recommendation. If age is still more than 85, then TAVI you have to do over surgical. It is a strong recommendation. So as the age goes, the more risk factors, TAVI is better than surgical surveillance, especially if transfemoral approach is possible. If transfemoral approach is not possible, then if surgical aortic valve replacement is possible, then do a surgical aortic valve replacement over TAVI. If surgical aortic valve replacement is also not possible, then you can do a transcatheter aortic valve replacement, even transapically through the apex of the heart only. You can do, not through the femoral artery. You can do aortic valve replacement apically only, LV apex only. You can do it. Okay, this approach, both the flow diagrams are given in number onward. You can go through students, postgraduate students. Okay, if you want to score high marks, you can go through that. The examiners may ask it. Okay, so this is about the interventions in aortic stenosis. So next, let us discuss about aortic regurgitation. Drink water. So let us discuss about aortic regurgitation. Aortic regurgitation, it could be either because of the valve problem or aortic root problem. Of late, the etiology because of the aortic root is increasing. Okay, more than 50% of the case of isolated aortic regurgitation is because of the aortic root involvement. Come to the cause of the pure aortic regurgitation, bicuspid aortic valve can produce a pure aortic regurgitation. Infected endocarditis because of the vegetations, the cusp perforation, then the loss of cusp tissue and indentation. It can produce aortic regurgitation. Rheumatic because of the commissural fusion and thickening of the aortic valves. Hypertension because of the aortic root dilatation and a thought of the valve margins can produce a aortic regurgitation. Marfan syndrome, aortic root dilatation, the prolapse of the valves and the taut margins and the thickened aortic valves can produce aortic regurgitation. Ankylosing spondylitis, there can be aortic root dilatation and thickening of the aortic valves. Aortic dissection, trauma, aortic tear and laceration, where the support to the aortic valve will be lost in these cases. A degenerative aortic valve because of the aortic root dilatation and thickening of the aortic valve. A VSD, a valve prolapse and it will go and attach to the septal defect in a VSD. Then syphilis, there will be atherosclerosis, aortic root dilatation, a taut valve margin and a thickened aortic valves. Then you have a rheumatoid arthritis which can produce isolated aortic regurgitation and a discrete subaortic stenosis. Come to the valvular causes. Okay, the valvular causes. The common causes are calcificamus, infected endocarditis, trauma, bicuspid aortic valve, rheumatic etiology, ventricular septal defect, then subaortic stenosis, aortic valvoplasty, Marfan syndrome, then bioprosthetic degeneration of late is one of the common cause for this valvular aortic regurgitation, which is the common etiologies. The uncommon are the unicommissural and quadricuspid aortic valves, SLE, ankylosing spondylitis, Crohn's disease, rheumatoid arthritis, Takayasu, Whipple's disease, then rupture of congenitally fenestrated valve, especially in hypertension, of the rare causes of aortic regurgitation, the valvular cause. Coming to the aortic root causes, the degenerative cause, the relapsing polychondritis, seronegative arthritis like psoriasis, reactive arthritis, syphilis, bicuspid aortic valve, the dissection of the aorta, ulcerative colitis, Behçet's disease, osteogenesis imperfecta, hypertension, anorexic drugs, joint cell arteritis. These are the causes of aortic root diseases which can produce aortic regurgitation. Now here, coming to the pathophysiology of the chronic aortic regurgitation, what happens here is because of the regurgitation back of the blood from aorta to the LV, there will be increase of the LV end diastolic pressure. Okay, the stroke volume also will increase. Okay, because the end diastolic volume is increased, stroke volume will increase, and there is a decreased diastolic blood pressure. Decreased diastolic blood pressure will be there. Okay, and then because of the regurgitation back of the blood into the LV, the effective stroke volume will be reduced in aortic regurgitation. The effective stroke volume will be reduced in aortic regurgitation, or a forward stroke volume will be reduced. Okay. Now, different scenarios I'll tell, and how it will affect the aortic regurgitation. For example, normally the end diastolic volume is 150 ml, normal heart, and end systolic volume is 50. So the stroke volume is 100 ml. The stroke volume is 100 ml, and the ejection fraction is stroke volume divided by end diastolic volume, that is 100 by 150. So that is 0.67 is the ejection fraction, and LV end diastolic pressure is 10 mm of Hg. This is a normal scenario. What happens in compensated aortic regurgitation? End diastolic volume will be increased 250 because of the regurgitation. The end systolic volume is 50. So the stroke volume is around 200. 250 minus 50, that is a stroke volume 200. Out of its 200, the 100 will regurgitate back, the 100 only will be pumped forward. So the effective forward stroke volume is only 100 ml. And what is the ejection fraction? The stroke volume is end diastolic volume minus end systolic volume, that is 200. So 200 divided by 250, end diastolic volume is 250, that is the ejection fraction, that is 0.8. 0.8. This is a chronic compensated AR, students. Next is chronic decompensated AR. Here end diastolic volume is still more higher, 300. End systolic volume is 150. So the stroke volume is end diastolic volume minus end systolic, that is 300 minus 150, that is 150 ml. Out of this 150, 75 ml will come back, regurgitate. 75 only will be pushed forward, that is forward stroke volume is 75. The ejection fraction is 150 is the stroke volume divided by end diastolic volume, that is 300, that is 0.5. This is chronic decompensated AR, student. Then you have acute AR. In acute AR, end diastolic volume is 170, end systolic volume is 50. So stroke volume is 170 minus 50, 120. Out of this 120, the 50 will come back, the regurgitation. So only 60 ml will be forward stroke volume. The forward stroke volume is only 60 ml. The ejection fraction is stroke volume divided by end diastolic volume. Stroke volume is 120 divided by 170. So the ejection fraction is 0.71. And here in acute AR, the end diastolic pressure is too much elevated, that is 50. Okay. Whereas in a chronic decompensated AR, the end diastolic pressure is LV end diastolic pressure is 25. In a chronic compensated, LV end diastolic pressure is 12. Normal is 10 students, LV end diastolic pressure. Because the regurgitation of the blood, end diastolic pressure is increasing. These are different scenarios. And after valve surgery, end diastolic volume will become 230. End systolic volume is 130. So the stroke volume is around 100. And ejection fraction is 0.43. Ejection fraction is, that is 100 divided by 230, that is 0.43. And LV end diastolic pressure will be more than 15 after the correction, valve surgery. So there is a flow diagram in Brownwell. You can go through this about how the volumes will vary in different compensated, decompensated, after surgery, acute AR. The volumes he has given, you can go through, students. Okay. Now coming to the stages of chronic AR. Stages of chronic AR, stage A, where it described under valve anatomy, valve hemodynamics, hemodynamic consequences, and then symptoms. Stage A, only there will be at risk for valve aortic regurgitation. For example, they'll have a bicuspid aortic valve, sclerosis, rheumatic heart disease, then root disease, or infective endocarditis. But there won't be any hemodynamic, valve hemodynamics won't be altered, or there is no any hemodynamic consequence also, and there will be asymptomatic also. Stage B is a progressive AR. It's classified into mild and moderate. How it is classified into mild is depending on the jet width of the regurgitation. The jet width, if it is less than 25% of the LVOT, it is mild. Vena contracta less than 0.3. What is vena contracta? Vena contracta is the initial portion of the jet, okay? The smallest portion of the jet before it become regurgitation. Once it becomes regurgitation, it becomes widens the flow of jet. That initial part where there is a narrow part, that is the vena contracta. The vena contracta is less than 0.3 in a mild AR. The regurgitation volume is less than 30 ml. The regurgitation fraction is less than 30%, and the effective regurgitation orifice is less than 0.1 centimeter square. 0.1 centimeter square. Okay, and angiographically AR will be 1 plus in them. 1 plus. This is a mild AR. B stage B progressive mild AR. A moderate AR, the jet width is between 25 to 64% of the LVOT. Vena contracta is 0.3 to 0.6 centimeter. Regurgitation volume is 30 to 59 ml. Regurgitation fraction is 30 to 49%. Then effective regurgitation orifice is 0.1 to 0.29. And angiographically, the AR will be 2 plus. Okay, this is stage B where they are asymptomatic. Okay, but still they will have mild and moderate AR students. So next is stage C where it is a severe AR but they are asymptomatic. So severe AR is characterized by the jet width more than 65% of the LVOT, the vena contracta more than 0.6 centimeters, and a flow reversal in the ascending aorta, and a regurgitate volume more than 60 ml, regurgitation fraction more than 50%, and an effective regurgitation orifice more than 0.3 centimeter, and angiographically +3 +4 regurgitation. This is severe AR. Severe AR has been classified into C1 and C2 depending upon the ejection fraction. If ejection fraction is more than 50%, it is stage C1. If less than 50%, stage C2. In stage C1, when ejection fraction is more than 50, the LV end systolic diameter will be less than 50 mm. Whereas in stage 2, when EF is less than 50, the LV end systolic diameter will be more than 50. Or the indexed LV end systolic diameter may be more than 25 mm per meter square of the body surface area. This is stage C, students. Okay, asymptomatic but severe AR. Then stage D is symptomatic severe AR. ABCD is similar classification compared to AA students. So everything given in brown word. You can go through the flow charts, nicely given. Symptomatic severe AR, they will have all the characteristics like the LV jet width, the regurgitant jet width is more than 65% of the LVOT, vena contracta more than 0.6, flow reversal in the ascending aorta, then regurgitation volume more than 60 ml, regurgitation fraction more than 50%, effective regurgitation orifice more than 0.3 centimeter square. Okay, stage is symptomatic severe AR. So this has been classified again into three types depending upon the ejection fraction. If ejection fraction is more than 50%, it is a normal. If mild to moderate LV dysfunction, EF will be 40 to 50%. Severe LV dysfunction, EF will be less than 40%. Okay, in the stage D, depending upon the EF, they are classified into mild to moderate LV diastolic dysfunction, severe LV diastolic dysfunction. Okay. So coming to the symptoms of aortic regurgitation. Symptoms of aortic regurgitation, so they can have a dyspnea because of the increased LV end diastolic pressure. Okay, they can have an angina because of the decreased diastolic blood pressure. Coronary underfilling will occur. Okay, they will have tachycardia. They can have tachycardias. Then the physical examination, the pulses, you can get the pulses. Water hammer pulse, you will get water hammer pulse. Okay. The other signs, physical signs, top to bottom, which I told in aortic regurgitation, which you have to look. Again, all those things. Okay, Lighthouse sign, Landau sign, Becker sign, Demuside sign, Quincke's sign, dancing carotids, locomotor brachialis, collapsing pulse, biciferens pulse, Trobbe's sign, Drosius sign, Hill signs, Rosenbach sign, Gerard sign, which I described when I discussed the case. All those things you have to look in a case of aortic regurgitation. Okay, then checking the blood pressure in aortic regurgitation is very important. You may keep on hearing the corresponding sound till the zero also, even though the intra-arterial blood pressure is 30 mm of Hg. So in aortic regurgitation, the muffling of the sound you have to take as a diastolic blood pressure, not the disappearance of the coroscope sound, students. This is very important. Only the muffling of the sounds you will take, but not the disappearance of the sounds to record the blood pressure in aortic regurgitation. Coming to the auscultation, in a mild aortic regurgitation, you will get an early diastolic murmur, which is a high pitched and a blowing in quality. In a severe, you will get a hollow diastolic murmur, which is a rough in quality, and a cooing type of murmur you get whenever there is a eversion of the aortic cusp or a perforation. Okay. Then, if the aortic root is involved, the murmur is better heard on the right side of the sternum. Okay, right aortic area, second space. If the aortic root is involved, like in a syphilitic AR. Then in an auscultation murmur, you get a severe aortic regurgitation because the blood will impinge on the mitral deflate and also the LV free wall. That is auscultation murmur, you will get it. The diagnostic testing, you will do 2D echo, then cardiac MRI and angiography you can do. Coming to the disease course, in asymptomatic patients with aortic regurgitation, you will do a mild to moderate cases 12 to 24 months echocardiogram, severe AR 6 months once you have to do echocardiogram. And decreased ejection fraction, BNP level, LV systolic function and volume will influence the prognosis in asymptomatic patients. In a symptomatic chronic AR, if they develop angina, they survive for 4 years. If they develop heart failure, they survive for 2 years. That is why we are forcing our patients to get undergo aortic valve replacement as early as possible, students. Then if the patient has NVH class 3 and 4, the 4-year survival rate is around 30% in aortic regurgitation. Coming to the treatment of chronic aortic regurgitation, the medical therapy, you will give hydralazine, nifedipine and felodipine, angiotensin converting enzyme inhibitor, beta blockers. If the patient is inoperable, you will treat like any other heart failure with diuretics, AC inhibitors and beta blockers. Coming to the surgical therapy, in a severe AR student, stage C and D, if they are symptomatic, you have to do aortic valve replacement. Okay, if they are asymptomatic, then the question arises, in asymptomatic patients, you will consider LVEF. If LVEF is less than 15 asymptomatic severe AR, you have to operate and put aortic valve replacement. Or if patient is going for other surgeries, you have to do a aortic valve replacement. But if EF is more than 50, then if LV end systolic diameter is more than 50 mm, or if LV end diastolic diameter is more than 65 mm, you have to operate if LVEF is more than 50. If LVEF is more than 50, but if LV end systolic diameter is less than 50 and LV end diastolic diameter is less than 65, you have to just follow the patient, students. Okay. So then, few points about acute AR and about bicuspid aortic valve. Acute AR, the causes are infected endocarditis, the dissection, the trauma and prosthetic valve dysfunction. Here what happens is there will be increase in the heart rate, tachycardia, suddenly LV end diastolic pressure will increase, forward stroke volume will reduce and left atrial pressure will increase, so which will produce pulmonary edema and they will be breathless, they can come with pulmonary edema. The physical examination in acute aortic regurgitation is soft S1 because of the blood flow to the LV, the mitral valve will move upwards. Okay, you will get a premature closure of the mitral valve, so you get a soft S1 and you may get a diastolic MR in acute AR. The blood from aorta will come to the LV, suddenly it rushes back to the LA, producing a MR that is called as a diastolic MR in acute AR. Then here, the early diastolic murmur in acute AR is of a short duration because of the equalization of the pressure between the aorta and the LV quickly. The later part of the diastole is diminished. Okay, the pressure increases in the LV suddenly. The regurgitation cannot occur during the later part of the diastole. It is only a short duration EDM in acute AR and it is low pitched. And the auscultation murmur in an acute AR, the presystolic part is abolished because the mitral valve will close because of the more pressure in the LV because of sudden regurgitation of the acute AR, more blood in LV, the mitral valve will close back. So that's why the presystolic part of the auscultation murmur you won't get in acute AR, students. In investigation, you will do 2D echo, ECG and chest X-ray. ECG and chest X-ray doesn't show LV enlargement in acute AR, students, unlike a chronic AR. Okay, right. Coming to the management, surgery is a treatment for acute AR. You will give dopamine and dobutamine, and nitroprusside should be given a medical line of therapy. Beta blockers and IABP are contraindicated because they reduce the heart rate, they increase the afterload by which they can decompensate the heart failure. If the infected endocarditis is the cause of acute AR, you have to treat antibiotic treatment for 1 week. But if the abscess develops or if the patient condition deteriorates, then immediately you have to operate in infected endocarditis also without giving antibiotics, or else you have to give 1 week of antibiotics for infected endocarditis in acute AR students. Okay. Then if there is a dissection is the cause, you have to treat the dissection. Okay, you have to treat the dissection. Coming to the bicuspid aortic valve, the incidence is around 1 to 2%. 70 to 80% are males in a bicuspid aortic valve, and it can be inherited autosomal dominant with a notch 1 gene inheritance. And here there will be aortopathy, there will be a weakness of the aortic wall producing a rupture. A dissection can occur in a bicuspid aortic valve where the incidence is 5 to 9% more. There can be associated with the MVP also, bicuspid aortic valve. They can present at any age. They can have aortic stenosis or aortic regurgitation or even infective endocarditis. Okay, so they can have systolic murmur or a diastolic murmur. The management is aortic valve replacement for bicuspid aortic valve, and aortic root you have to replace if it is more than 45 mm with ARRAS, or if it is more than 55 mm even without ARRAS, or if it is more than 50 if there is a family step dissection or rapid progression. Okay. So 3 scenarios, students: more than 45 with AS and AR, more than 55 even without ASR AR, or more than 50 with a family step dissection or rapid progression. You have to replace the aortic root in bicuspid aortic valve, students. There's some standard question in a case like this. If you get in the exam, they'll ask, what is the difference between acute AR and chronic AR? They'll ask students. Acute AR sudden in onset, chronic AR slowly develops. Acute AR because of more pressure, LV endoscopic pressure in the LV, so they can develop pulmonary edema. Then S1 is muffled in acute AR because mitral valve will prematurely close. Then LV apical impulse, it won't be shifted downward or outward. Even ECG and echo ECG and X-ray doesn't show LV enlargement in acute AR. In acute AR, the Austin murmur, the presystolic part will be abolished. The presystolic part will be abolished in acute AR. Then the pulse pressure will be very less in acute AR, and the peripheral signs, what you get in a chronic AR, you won't get in an acute AR. These are the differences between acute AR and chronic AR. They'll ask in the exam, students. And one more question is, what is the difference between syphilitic AR and rheumatic AR? Syphilitic AR, isolated AR can occur. Rheumatic AR, you will be associated with AS or mitral valve. Prominent peripheral signs you get in syphilitic AR. Syphilitic AR can be associated with the anginal pain. The murmur, because of the root dilatation, is better heard on the right side, right second aortic space compared to the left third space what you get in rheumatic AR. There will be calcification of the ascending aorta in a syphilitic AR, and VDR will be positive in the syphilitic AR. These are some of the differences between, then A2 will be a Thombour quality A2 in a syphilitic AR, students. These are some of the differences between syphilitic AR and rheumatic AR. Then they'll ask one more question, how do you assess the severity of AR? Severity of the AR. Severity of the AR is by the duration of the murmur, if there is a pulsus biciferans, hillside more than 60 mm of HG, LV displaced downward and outward, and marked peripheral signs, and if there is a Austin murmur, marked peripheral signs, LV displaced downward and outward, pulsus biciferans, hill signs more than 60, these are all the indicators the AR is very serious, student. Okay, there's some other question. One more question is, how do you distinguish a Austin murmur from a mitral stenosis? Mitral stenosis and Austin both are MDM murmurs. Mitral stenosis has a loud S1 and opening snap, which you won't get in an Austin murmur. In Austin murmur, you will get S3 and LV enlargement, whereas in MS, you won't get S3 and LV enlargement. There is a difference between Austin murmur and mitral stenosis murmur, students. Okay, so this is about aortic regurgitation. Next, let us move on to the rheumatic fever. I'll take break. So students, you in MS, MR, that is mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. When you get a case, definitely they'll ask about the rheumatic fever. Our patient gave history of rheumatic fever history when she was around 15 years of age group. So you should know about rheumatic fever. I want to discuss today with this case ASMR rheumatic fever also, so that it will be useful for all the four valvular lesions when you get a case. It is caused by rheumatic fever, a group A beta hemolytic streptococci, that is gas, okay, GAS, group A beta hemolytic streptococci. Following a latent period of 2 to 3 weeks of streptococcus pharyngitis, the rheumatic fever will develop. It is characterized by inflammation of the heart, the joint, skin, subcutaneous tissue, and central nervous system. The inflammatory process will cause damage to the collagen fibrils and subcutaneous connective tissue. That is, it produces fibrinoid degeneration. That is why rheumatic fever is also sometimes known as connective tissue disease or collagen vascular disease. A French physician, Lassigue, he told rheumatic fever will lick the joints, bites the heart. What is the meaning? It produces joint pain, but never produces deformity, rheumatic fever arthritis. But it damages the heart. So that is why it licks the joint but bites the heart. The French physician Lassigue told us. Coming to the epidemiology, there are different patterns of the rheumatic fever. For example, in a developing country like America, even before pre-antibiotic era, because of the improvement in the socio-economic status, there was a decreased incidence of rheumatic fever. In sub-Saharan countries, okay, and Africa, the African countries, so there is rheumatic fever is still on the increasing trend only. In some of the countries, developing countries like India, there is a decreasing trend of rheumatic fever. Rheumatic fever incidence is coming down because of the improvement in the socio-economic status. Okay, and then in some of the countries like Soviet Union, there is a resurgence. It has disappeared, but now it is again resurgence. And right now, Kyrgyzstan is known as the rheumatic fever hotspot of the rheumatic world. The rheumatic fever hotspot of the world is Kyrgyzstan right now. Coming to the pathogenesis, the agent, host, and the environment. The agent, as I told, it is group A beta hemolytic streptococci. Okay. Usually, the streptococcal group A hemolyticus pharyngitis, but not the skin infection, produces the rheumatic fever. The untreated streptococcal pharyngitis, the 3% will develop the rheumatic fever, the incidence. If 100 people will get streptococcal pharyngitis, 3 people will develop the rheumatic fever, students. Then here it is all because of the molecular mimicry. The T cells will cross-react with the streptococcal M protein and the cardiac myosin protein. Okay. Then you can see in the myocardium the ash of bodies. There can be a necrosis. Surrounding the necrosis, there will be histiocytes known as Anichkov cells. Then the molecular mimicry can be against a cardiac myosin or a laminin of the endocardium, or a tubulin of the brain, dopamine receptors of the brain, or lysoganglioside of the brain. A molecular mimicry against these things can occur, producing a clinical manifestation. Then coming to the host, there can be heritability also in developing rheumatic fever. 60% it is shown, runs in heritability is a factor in rheumatic fever. Come to the environment, rheumatic fever as socioeconomic status improves, the incidence of rheumatic fever reduces. Clinical feature, after a period of 2 to 3 weeks of streptococcal pharyngitis, okay, the rheumatic fever develops. During this latent period, there won't be any clinical or laboratory evidence of inflammation, students. 1/3 of the rheumatic fever will develop without any symptomatic pharyngitis. So in 1/3, they won't remember any pharyngitis is there. It develops after asymptomatic streptococcal gas infection, 1/3 of the patients. They are developing group A beta hemolytic streptococcal vaccine to prevent the rheumatic fever. It is in the stage phase 2, phase 3 trials. Okay. It mostly affects the children of 6 to 9 years of age groups. Okay. Especially in India and in a UAE. After the rheumatic fever, The juvenile MS can develop within 3 to 5 years only. Normally it takes 15 to 20 years, like in our case. She had 15 years, at 35 she developed the symptoms. Normally it takes 2 decades to develop the rheumatic heart disease. But in UAE and India, as early as within 3 to 5 years you can develop a juvenile MS. Juvenile MS. The illness rheumatic fever can usually begin with a high fever, or there can be even a low grade fever also can occur. The most common manifestation is polyarthritis, which occurs in 2/3 of the patient to 3/4 of the patient, followed by carditis and chorea. Coming to the each clinical manifestations, coming to the arthritis, the joint involvement is the most common manifestation occurring in almost some joint involvement will occur in at least 100% of the patients. Okay, it is very severe in young adults than in teenagers and children. The joint manifestation, it is migratory, ankle joint, then knee joint, like that it migrates. In some it can be additive. Additive means ankle joint to that knee and hip will be added. That is additive. In 2/3 of the patient, the ankle joint, the joint pain is severe for 1 week. It will persist for another 1 to 2 weeks. It will subside by 4 weeks maximum. If it doesn't subside by even by 4 weeks, then you have to consider a juvenile idiopathic arthritis or SLE. Okay. Then the rheumatic fever arthritis is asymmetrical, involves the large joint, the knee, ankle, elbow, wrist joint. Rarely involves the hip joint and the shoulder joint and small joints. Rarely hip joint, shoulder joint, small joints, or else ankle, knee, wrist, elbow joint. Then if you do a synovial fluid analysis, it will show a sterile inflammatory fluid in the joints. Okay. Then Jacquard's arthropathy you should know. Jacquard's arthropathy is deformities of the fingers and toes. Student Jacquard's arthropathy, because of recurrent rheumatic fever it can develop. RA factor will be negative. There will be swan-neck deformity. Erosions are not seen, and there is no signs of inflammation or no pain will be seen in Jacquard's arthropathy, and ulnar deviation of the 4th and 5th fingers will be seen. Jacquard's arthropathy. Okay, right. So next, these rheumatic fever arthritis will respond to the NSAIDs. The one more differential diagnosis is post-streptococcal reactive arthritis. Post-streptococcal reactive arthritis is a closed DD for acute rheumatic fever. Here, the latency period is very short. They can have a renal manifestation, but carditis is not seen, and they respond to anti-inflammatory medication. Post-streptococcal reactive arthritis. Next is carditis. The incidence is 40 to 90%. As the age increases, the incidence of carditis reduces. It is a pancarditis involving endocardium, myocardium, and pericardium. If pericardium is there, will be pericarditis, rub will be there. Myocardium, there will be a cardiomegaly and heart failure. Endocardium, they can have a mild regurgitation, most common. Very rarely AR can be there. ECG will show blocks because there is a myocarditis, and all the patients with carditis, they are to undergo 2D echocardiogram. The rheumatic fever pancarditis rarely develop tamponade or constitutive pericarditis. They won't go for that. Next, pseudomonas chorea. Pseudomonas chorea, it occurs very late in the manifestation of acute rheumatic fever. So many times it can be the only manifestation. The evidence of acute phase reactants like ASAR, CRP, WBC count all may not be evident whenever there is rheumatic chorea. In females, it is more common compared to males, especially after puberty. The incidence in females is very much more common compared to the males. It occurs after a latent period of 6 to 8 weeks. It can persist for 8 to 15 weeks, or even sometimes for 2 years it can persist. Milking sign, jock in the box, or some other signs in rheumatic chorea. It disappears during sleep. Rheumatic chorea can occur with carditis, but it never occurs with arthritis together. Okay, students, right. Next is subcutaneous nodules. It resembles the rheumatoid nodules. It is discrete, painless, 0.5 to 2 centimeters in diameter. It occurs on the occiput, elbow joint, ankle joint, tendoachelis joint. The subcutaneous nodules occurs on the olecranon process, unlike a rheumatoid arthritis where it will be in the distal part of the arm will be there, the rheumatoid nodules. Rheumatoid nodules can persist for some weeks but rarely persist more than 1 month. If rheumatoid nodules are there, that indicates underlying carditis. Recurrent bouts of rheumatoid nodules indicates a severe cardiac disease undergoing the patient. 1 to 5% is the occurrence rate of the rheumatic fever nodules. Okay, rheumatic fever nodules. Next is erythema marginatum. It is less common. It will occur in the upper part of the arm and chest, but never on the face. It is centrifugal, so central part will disappear, heals. It is pink, non-purpuric lesions, and it occurs early or late. Usually, it occurs in the setting of carditis, the erythema marginatum. Okay, students, right. The other manifestation, 38 to 40 degrees centigrade to 40 degrees centigrade fever can be there. Rheumatic pneumonia, abdominal pain, epistaxis. These are some of the clinical manifestations. Coming to the diagnosis, the major criteria is carditis, polyarthritis, subcutaneous nodules, erythema marginatum, chorea. The minor criteria is clinical fever and arthralgia. Investigation, rise CRP, ASLO, WBC count, and PR interval prolongation. Minor criteria. Then essential criteria is the evidence of streptococcal group A beta hepatitis streptococci infection within 45 days, either by a raised ASLO or streptococcal antigen test or a throat culture positive test or a recent scarlet fever. These are essential criteria. So, what is the diagnostic categories? A primary episode of rheumatic fever means there should be at least a 2 major or 1 major, 2 minor plus a essential criteria. This is a primary rheumatic fever. Recurrent attack of rheumatic fever in a patient without RHD. Patient is not having RHD. In the recurrence of rheumatic fever, again 2 major or 1 major plus 2 minor plus a essential criteria. Whereas a recurrent attack of rheumatic fever in established RHD means only 2 minor is enough, students. Only 2 minor plus evidence of streptococcal infection, that is the essential criteria. Only 2 minor is enough. Suppose if the patient is having rheumatic chorea, you don't require any major, any minor, neither essential criteria if a rheumatic chorea is there. Then, if there is a insidious onset of rheumatic carditis or a rheumatic heart disease, that is enough to establish a diagnosis of RHD. Do not require any other criteria. And one more thing, in a hyper-endemic areas, for example, country like India, if you consider a monoarthritis as a major manifestation, monoarthritis can occur in 15% of the patient students in arthritis, monoarthritis. So, monoarthritis is a major criteria, or a temperature more than 37.5 degrees centigrade as a minor criteria, then the value, the sensitivity of this Jones criteria is increased. Okay, the modified Jones criteria is increased. So, Jones criteria is a must. All the PG students should know the major criteria, minor criteria, and some of the modification for a PG level, as I told. Okay, the reactivation in established RHD only 2 minor is enough. Chorea, you don't need anything. And in a hyperendemic area like India, a monoarthritis or a temperature more than 37.5 is a minor, monoarthritis is a major. Will increase the sensitivity of the modified Jones criteria. Okay, students. Now, next is investigation of the suspected rheumatic fever. What are the tests you do? You do WBC count, CRP, ESR, ASLO titer, throat swab culture, blood culture, chest X-ray, ECG, 2D echo, anti-DNAs. Okay, in the late stage you may get anti-DNAs, antibodies. These are the tests which you do in a suspected rheumatic fever, and you will do test for alternative diagnosis depending upon the clinical features. For example, if there is high fever, you will do repeated blood culture to rule out infective endocarditis, peripheral blood smear for sickle cell anemia. For arboviral infection, you will do a serology and autoimmune markers for autoimmune reactive arthritis. Then for rheumatic chorea, you will do copper, ceruloplasmin, and drug history you will take, drug screen you will take, and joint aspiration you will do, okay, for a possible septic arthritis to rule out. Okay. So there are the other tests if you consider alternate diagnosis apart from rheumatic fever, you have to do in a case of rheumatic fever. Now, coming to the treatment of rheumatic fever, the bed rest you have to give, okay, to lessen the joint pain in acute rheumatic fever. then you have to make them ambulant only once the fever has subsided or all the acute inflammatory reactants are returned to normal. Strenuous exertion should be avoided, especially in carditis. Strenuous exertion should be avoided in carditis. Then in an acute streptococcal pharyngeal infection, you will give and in acute rheumatic fever, intramuscular benzathine single dose penicillin you will give, and erythromycin if they are allergic to the penicillin. But there is little evidence that corticosteroids and immunoglobulins will prevent or modify the heart disease. Then you have to give aspirin, anti-inflammatory dose in acute rheumatic fever. The dose is 100 mg per kg body weight in 4 to 5 divided doses. You can use steroids 1 to 2 mg per kg body weight prednisolone. A mild attacks with little evidence of carditis, you can give 1 month of treatment. In severe cases, you can use steroids for 2 to 3 months. In some cases, severe cases, they may have the rheumatic activity in spite of treatment for 6 months. And if inadequately, if you treat, they can develop MR, which may need a prompt surgical management. So this is a treatment of acute rheumatic fever. Now coming to the prevention, very important. One is primordial prevention. Primordial prevention is improving the socio-economic status of a country. That is primordial prevention. Then primary prevention. Primary prevention, if you give antibiotic to the group A beta-hemolytic streptococci pharyngitis, reduces the rheumatic fever incidence by 70%. And if you give intramuscular benzathine penicillin, it reduces the rheumatic fever by 80%. So the antibiotics you give in a primary prevention is benzathine penicillin, a single IM, 1.2 million units, that is 12 lakh units if more than 30 kg, 60,000 units if less than 30 kg. Then oral penicillin, penicillin V, you will give perorally for 10 days, 250 to 500 milligram TAD for 10 days. Erythromycin compounds you can give perorally for 10 days. Dose is depending upon the formulations, it varies. Erythromycin. Then next is secondary prevention. Secondary prevention, usually the evidence for every 2 weeks is strong compared to the interval of 3 to 4 weeks secondary prevention injections. But WHO recommends 3 to 4 weeks injections. But evidence is better for 2 weeks injection once in 2 weeks rather than 3 to 4 week injections. So the antibiotics are benzathine penicillin, okay. The mode of administration is a single IM route once in 3 to 4 weeks. More than 30 kg, 1.2 million units, 12 lakh. Less than 30, 60,000 units. Oral penicillin V you can give, that is 250 milligram BD. Sulfonamides you can give if more than 30 kg 1 gram, less than 30 kg 500 milligram. Or erythromycin oral 250 mg BD you can give. Okay, this is a secondary prevention. Then the duration of secondary prevention is also very important. Okay, suppose if the patient has a rheumatic had a rheumatic fever without proven carditis, there is no carditis, only rheumatic fever, then you give for 5 years or 18 years, whichever is longer. If no carditis, if there is a mild carditis, you will give for 10 years or 25 years, whichever is longer. If there is an established rheumatic heart disease or a severe carditis, you will give lifelong therapy, students. You will give lifelong therapy. So very simple. Without carditis, 18 years or 5 years, whichever is longer. Mild carditis, 25 years or 10 years, whichever is longer. Established RHD or a severe carditis, lifelong therapy of secondary prevention of this benzathine penicillin or sulfonamides, erythromycin or oral penicillin. There is a vaccine, a future perspective. They are developing it against group A beta-hemolytic streptococci gas organism. That is in phase 3 trials. Then one more entity you should know about is PANDAS. PANDAS is a pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. PANDAS. Okay. So this is about acute rheumatic fever. I have taken from Brownwood. So all the 3 things, aortic stenosis, aortic regurgitation, acute rheumatic fever, I have taken from Brownwood, students. At the end of this discussion, I'll give audio clip of AS and AR, the ESM and EDM. Okay, I'll give. You can listen to that. Or I acknowledge the Littman library for this. Okay, I have taken from Littman library. I acknowledge that. All of you can Littman library. You can listen to the murmurs. Then ECG, X-ray and the flow diagrams for the indication of surgery. In the PPT I have shown, you can go through the PPT after the discussion of this case. So all the valvular lesion students, mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, I have taken from Brownwald. So that postgraduate students should be benefited. They should be able to answer all the questions. That is why I have taken from Brownwald. Okay. So, and even rheumatic fever I have taken from Brownwald. We discussed in detail about the discussion on this the valvular disease, aortic stenosis and aortic regurgitation. I want to put up some of the X-ray, ECG and flow diagram showing the indications for intervention and surgery for aortic stenosis and aortic regurgitation. Whatever the ECG, the X-ray and flow diagram are taken, I acknowledge Google search. And also for craniometric line, whatever the diagrams I have taken, I acknowledge the Google search which I did for the eye cervical cord lesion students. So let us discuss now today ASAR, ECG, X-rays and the indication for intervention. First is ECG of aortic stenosis. So in ECG of aortic stenosis, there will be a concentric hypertrophy LVH. You can see a very tall R wave. Students, you can see in the V4, V5, V6, a very tall R wave you can see. And also you can see deep S waves in V1 and V2. Okay, and you can see the strain, LV strain, because of the pressure overload on the left ventricle. You can see ST segment is depressed and it is asymmetrical T-wave inversion. Okay, unlike a ischemic T-wave inversion where it is symmetrical, the limbs, both the limbs will be symmetrical, whereas here it is asymmetrical T-wave inversion in V4, V5, V6. So this is the ECG of aortic stenosis. Next, come to the chest X-ray of aortic stenosis. Chest X-ray, here you can see students, this is a concentric hypertrophy. So the red arrow mark is showing the rounding of the LV. So a rounding of the LV is seen. This is a feature of LVH, a concentric hypertrophy of aortic stenosis, rounding of the LV. Then come to the guidelines for the management of patient with aortic stenosis. Okay, this I discussed in theory part. Now I want to put a flow diagram and show you. For example, if there is an abnormal aortic valve with a reduced systolic opening, that is aortic stenosis, it can be a severe AS. A severe AS is Vmax more than 4 meter per second or a gradient more than 40 mm of Hg. Okay. If the severe AS is symptomatic, it is again classified into D1, D2, D3. Okay. Suppose in a severe AS, if it is symptomatic, that is D1, where Vmax is more than 4 meter per second and the gradient is more than 40 mm of Hg, you have to do a aortic valve replacement. That is a class 1 indication. Suppose if severe AS is asymptomatic, it is stage C. Stage C is again classified into C1 and C2. In C2, EF is less than 50%, whereas in C1, EF is more than 50%. Suppose in an asymptomatic aortic stenosis in a stage 2, if LVEF is less than 50%, then again you have to do the aortic valve replacement, class 1 indication. Or if the patient is going for other cardiac surgery, then also you have to do aortic valve replacement. That's a class 1 indication. Or if the patient in a asymptomatic stage C, suppose if the patient is having a Vmax more than 5 meter per second and the gradient is more than 60, that is very severe AS, asymptomatic and a low surgical risk, you have to do aortic valve replacement. That is class 2A indication. Suppose in asymptomatic stage C, if there is abnormal excess tolerance test, again you have to do aortic valve replacement. That is class 2A indication. And suppose if Vmax is more than 0.3 meter per second and if there is a low surgical risk, then is a class 2B indication in asymptomatic stage C. Okay. Now coming here, the D1, D2 and stage B. So here Vmax is less than 4 meter per second, that is in between 3 meter per second or 3.9 meter per second, and the gradient is 20 to 39. Okay. And if the patient is symptomatic with this finding, and if the ejection fraction is less than 50, okay, then it is stage 2. Okay, that is D2, stage D2. So in stage D2, EF is less than 50%, Vmax is less than 4 meter per second, gradient is less than 40. In them, it is a 2A indication, aortic valve replacement. And there is this called as a low gradient AS. Low gradient AS because EF is less than 50. Low gradient AS. And here what happens sometimes, the LV is so much hypertrophied, the ejection fraction will be more than 50, but the stroke volume is less than 35 ml. Okay, that is stage D3. Okay, here LVEF is normal, but because the volume is very less LV volume, because of the hypertrophy, the ejection fraction, though it is more, the stroke volume is less than 35, and aortic valve area will be less than 1 centimeter square. This is stage D3. Stage D3 symptomatic. So then here also aortic valve replacement is class 2A indication in stage D3. So stage 2 to stage D3, it is aortic valve replacement is class 2A, whereas stage D1, it is aortic valve replacement is class 1 indication. Then if it is a patient with a Vmax 3 to 3.9 meters per second, if the gradient is 20 to 39 mm of H, if they are asymptomatic, it's called progressive AS, that is stage B. In stage B, asymptomatic, only if you are doing other cardiac surgery, you can put a valve, that is aortic valve replacement. It is a class 2A indication. So this is the recent guidelines for the aortic valve replacement in aortic stenosis students. Okay, right. So next is chest X-ray of aortic regurgitation. Here you can see the LV, the eccentric enlargement of the LV, the dilatation of the aorta. You can see here aortic regurgitation chest X-ray. Then ECG of the ear, aortic regurgitation is a diastolic overload. So you, because of the aortic regurgitation, the LV will have a diastolic overload. So the ECG will show, you can see here Q wave, a deep Q waves in V5, V6, and a tall T wave and a tall R wave. All these indicates diastolic overload, a tall T wave, a tall R wave, and Q wave. Where the systolic overload, as I shown in the ECG of aortic stenosis, it will be a IST depression. IST depression will be there, and T wave inversion in a systolic overload, whereas in diastolic overload, Q wave, tall R wave, tall T wave is seen. Next is guidelines for the management of patients with aortic regurgitation. So in this guidelines, if it is aortic regurgitation, so it is a severe AR. In severe AR, it could be a stage C and D. C is asymptomatic, D is symptomatic. Severe AR means vena contracta is more than 0.6. Vena contracta is the initial portion of the jet, okay, before it expands, that is vena contracta. If that is more than 0.6 centimeters, then holodiastolic aortic flow reversal. If the regurgitate volume is more than 60 ml beats, regurgitation fraction is more than 50%, and effective regurgitation orifice more than 0.3 centimeter square, LV dilatation. This all indicates severe AR. In a severe AR, if it is symptomatic, it is stage D, asymptomatic, stage C. In a symptomatic severe AR, aortic valve replacement is a class 1 indication. Suppose in a severe AR asymptomatic, then if EF is less than 50, it is called as stage 2, then again a class 1 indication for aortic valve replacement. In a asymptomatic stage C, severe AR, if they are going for other cardiac surgery, again it is a class 1 indication, aortic valve replacement. But in a asymptomatic stage C severe AR, if ejection fraction is more than 50%, then you have to see left ventricular end systolic diameter. If left ventricular end systolic diameter is more than 50, it is a class 2 indication. And if EF is more than 50%, and if left ventricular end diastolic diameter is more than 65, again it is a class 2B indication. But EF is more than 50%, but if LV end systolic diameter is less than 50, LV end diastolic diameter less than 65, you have to just periodically monitor. See, end systolic diameter and end diastolic diameter, if it is not enlarged, you can just periodically monitor. But if end systolic diameter is increased and left ventricular end diastolic diameter is increased with EF more than 50, it's a class 2A indication for aortic valve replacement. If left ventricular end diastolic, class 2B, end systolic diameter increased to more than 50 mm, it is a class 2A indication. Then you have a progressive AR, that is stage B progressive AR. Here vena contracta is less than 0.6, regurgitant volume is less than 60 ml per minute, regurgitation fraction is less than 50%, effective regurgitant orifice is less than 0.3 centimeters. It is a progressive AR or stage B. Here only if the patient is going for other cardiac surgery, then it is 2A indication. If not going for other cardiac surgery, only progressive AR, then periodic monitoring is enough, students. Okay, so this is the latest American Cardiological Society guidelines for the management of aortic regurgitation. So this is comes the discussion about AS and AR, students. Okay, thank you, students.